Thank you all for coming to the third annual David Hume lecture on human nature. You might wonder why we should have a topic like race medicine for the David Hume lecture on human nature. Well, issues about race and racism suffuse the history of philosophy. They suffuse the history of the humanities, the social sciences, and indeed the natural sciences. Race is the ghost that haunts our disciplines. David Hume, whom I admire very deeply, that's why I established the David Hume lecture, was no exception to this. And in fact, his career intersected with race importantly at 2 points, one of which is rarely spoken about, and that's the first I wish to mention. As you may know, David Hume went off to university at the age of 11. He was expected to study law. He confessed in his autobiography that the study of law, quote, made me nauseous, end of quote. And he decided to devote himself to the study of classics and philosophy. After graduating, he sat down to work and resolved to study for no less than 10 years, read basically everything in the Western canon. But after a while decided he would benefit from a more active scene of life, as he put it. So he got a job, which lasted only a few months, as a clerk in the city of Bristol. This was in the early 18th century. It was at a time when Bristol was the main slave port in the United Kingdom. It was later taken over by, that role was taken over by Liverpool later on. Not only that, David Hume worked for a sugar importer in Bristol. It was, of course, importing sugar produced by slave labor in Jamaica. So that's the first intersection. The second intersection is a notorious passage from an 1853 work called Of National Characters, which is blatantly and explicitly racist. In the most horrible way that we found people in the 18th century expressing quite frankly and openly. Attitudes today are often no less horribly racist, but they're somewhat less explicit. So this is a ghost. This is a ghost that needs to be exorcised. And the way to exorcise this ghost is to learn how to think about these issues, to become acquainted with these issues. Because today, the influence of ideas of race is no less momentous and no less destructive than in past decades and indeed in past centuries. So it's with great joy that I welcome Dorothy Roberts to the University of New England. Dorothy Roberts, now I have to resort to my notes here, because she has like all these jobs, all these professorships. She is an acclaimed scholar of race, gender, and law. She's the 14th Penn Integrates Knowledge Professor at the University of Pennsylvania. Isn't that just such a cool idea? An Integrates Knowledge Professor. This is what attracted Dorothy, she told me today, to the University of Pennsylvania, that her very strong and very effective form of interdisciplinary scholarship would actually have a home, rather than, as is so often the case, be paid lip service to by universities who treat this as the latest buzzword. Okay, she has a joint appointment in the Department of Sociology and the law school, where she also holds the inaugural Raymond Pace and Sadie Mosell Alexander Chair, and she is university professor as well. Her path-breaking work in law and public policy focuses on urgent contemporary issues in health, social justice, and bioethics, especially as they impact the lives of women, children, and African Americans. Her major books include Fatal Invention, How Science, Politics, and Big Business Recreate Race in the 21st Century, and that is just such a wonderful, wonderful book. that's what made me a fan of your work. And then when we met at that Holocaust conference last year, it must have been, I wasted no time saying, would you like to come to Maine and speak? And I don't know how I persuaded her, but she agreed. She's terribly overcommitted, but she agreed to be here. Right, so there's that book, and then Shattered Bonds, The Color of Child Welfare, and Killing the Black Body, Race, Reproduction, and the Meaning of Liberty. I give you Dorothy Roberts.
Thank you, David, for that really interesting introduction about David Hume, and for inviting me here, and for your work on race and humanity. And thank you all for coming on this chilly night. I'm going to talk about race medicine, the way in which doctors practice medicine in this country that's so based on race, and the history of it from the time of slavery to the present day. When I was working on my book, Fatal Invention, I interviewed a public health researcher and professor named Michael Bird, who was at the Harvard School of Public Health. And he said, well, to understand race medicine, which is the US practice of medicine, you have to understand slave medicine. And you have to understand that for 200 years and more in the United States, Black people were treated in a separate subsystem of medicine just for enslaved people. A subsystem of medicine that treated Blacks for the benefit of their masters or neglected them. One or the other. Either it was to heal them so that they could work for their masters, or neglect their health if it didn't matter to their masters. And it also was medicine that was developed in the context of the scientific invention of race. So the practice of medicine at the very beginnings of this nation happened simultaneously with the invention of the concept of race, the idea that human beings are naturally divided into groups that are distinct enough to call them different subgroups of the human species. Everybody in the group is enough like each other and different enough from people in other groups that we can distinguish them clearly enough to call them races. And that idea came out of slavery, so it was invented in order to support slavery. It wasn't the case that first there were races and then people came up with harmful ideas about races. It was first that there was racism and the desire for certain people to dominate other people and justify it. And in order to justify that domination and in order to govern people in that way, they had to invent races. And so the enslavement of Africans led to the invention of this grouping of people that's supposed to be natural, and placing them in a hierarchy. Of course, the whole point of doing this was to put Europeans at the top of the hierarchy, because they were entitled to be masters of and hold as property other human beings, and put Africans at the bottom, because they were the people who were born to be slaves, who naturally were supposed to be enslavable. So again, in order to understand medical practice in the United States, you have to understand that it began in this context of creating race. part of race medicine was that enslaved Africans could be treated like property. They were property. They weren't just treated like property. They were property, which meant that white doctors and scientists could use them any way they wanted to in medical experimentations. You know, just like you could use a rat in a scientific experiment, you could use an enslaved human being in a scientific experiment. So one example is Dr. J. Marion Sims, who is lauded as the father of modern gynecology and obstetrics in the United States. He perfected his methods on enslaved women who, of course, without their consent, he tested all sorts of procedures and tools without anesthesia on these women, and they had absolutely no right whatsoever to decide whether they wanted to be part of these experiments or not. Then, after hundreds of years of this separate subsystem of slave medicine, came another 100 years of blatantly segregated medicine. Now you can see how much of US history is made up of medicine based on enslaving people and considering them, not even human property. And then another 100 years of segregated medicine, where just like there were segregated drinking fountains and swimming pools and hotels and schools, there were segregated hospitals, either hospitals for white people and for black people, or hospitals that had separate wards for black people and white people. And of course, we know that when you have this kind of official segregation, as the court found in Brown versus Board of Education, it's the subordinate group gets inferior care. I don't think anyone believes, and few people believe anymore, that separate is equal. There's not only an injury in the separation, but also those in the colored patient wards got worse care than those in the white wards. Harriet Washington, in her book Medical Apartheid, The Dark History of Medical Experimentation on Black Americans from Colonial Times to the Present, details in a way I don't have time to today, all the ways in which African Americans were subjected to medical experimentation, to neglect, to inferior care for hundreds of years. And I'm going to show you that that type of medicine, race medicine, continues to today. So let me give you some examples. The Tuskegee experiment. How many here have heard? Almost everyone's heard of it. Have you all heard of the Tuskegee experiment? There's misinformation, a lot of misinformation about what actually happened in the Tuskegee experiment. But this was a government, federal government funded study to determine whether or not African Americans experience syphilis differently from other people. And so the scientists allowed these sharecroppers who enrolled in the study to die from syphilis, even though there were treatments for it, so that they could study the effect on their corpses after they died. And this was based on the idea, coming out of slavery, that black people's bodies were different, that they had different diseases and they experienced disease differently. And notice the years. This is not ancient history. this experiment continued until 1972. That might seem like ancient history to some of the students here, but I was in high school in 1972. So this was, seems very recent history to me. Have you heard the immortal life of Henrietta Lacks? You may have said in many universities that's the book of the year. All the students read it. Henrietta Lacks was a woman who was treated by the Johns Hopkins Hospital in a colored ward there, because at the time, 1950, when she went for treatment for cervical cancer, there was a separate ward for black people. Again, not that long ago. And her tumor was biopsied, a piece of it was taken without her consent, though there's some question about whether doctors would have taken it without consent from any patient. It's possible, but her tumor, turned out that the cells from her tumor were immortal. They grew and grew and multiplied and multiplied and multiplied, and they've been beneficial to millions and millions of people around the world as a result of their use in medical studies. But one of the theories at the time at the hospital, why it was easy to take tissue or perform experiments on people in the colored ward, was the idea that they couldn't pay for their care, and so they should contribute in some way. This was just compensation, using their bodies in some way for the medical care that they got. Now, so far I've talked primarily about the way in which black bodies seen as property could be subjected to experimentation and exploitation. So that the practice of medicine during slavery was very much linked to the status of black people as property that could be used in whatever way their masters wanted to use them. But another aspect of it was the idea that black people's bodies were different. They were peculiar. They had their own pathologies and diseases, and they experienced common diseases differently. And that idea was made into a more precise science by Dr. Samuel Cartwright, a physician who was trained at my university, University of Pennsylvania. And he was asked by the Louisiana Medical Association to do a study of Negro diseases. And so he studied enslaved Africans in Louisiana and wrote this report in 1851 of the diseases and peculiarities of the Negro race. And he discovered that there were these special diseases that only black people had. One of them was the disease drapetomania, which is a combination of two Greek words, meaning the disease the mental disorder that makes people run away. And his theory was that black slaves who fled plantations were suffering from a mental disorder. Now that might seem strange. Why would there be a mental disorder to escape from slavery? Well, that was connected to another one of his theories, which was that black people needed to be forced to work because apart from slavery, they wouldn't work hard enough, and that was bad for their bodies because black people blood was different from white people's blood. Blacks had difficulty vitalizing blood. Their lungs did not put enough oxygen in the bloodstream. And so in order to vitalize black people's blood, they had to be forced to work. And so his theory was that blacks were enslaved by freedom because their health was worse, and it was only in slavery that they were free to have good health. So by thinking of blacks as having different kinds of bodies, he was able to justify slavery as a form of freedom for black people. So then, if black people are really free under slavery and have better health under slavery, you must be crazy as a black person to want to escape slavery. So that was evidence of a mental disorder. Now, what do you think is the remedy for the mental disorder of drapetomania? Beating slaves into submission so that they could take their healthy and proper role. But notice he's making a medical argument to support enslaving people. And so very early, in the 1850s, I mean, there were other examples of this even before, but by the 1850s, there was a very well thought out, supposedly demonstrated through his scientific investigations, idea that slavery was good and that black people and white people were separate types of human beings. They had separate bodies. And the idea that blacks had different diseases from whites and experienced common diseases differently was intimately linked with justifying enslaving black people. Lundy Braun, a professor at Brown University, I think captures this idea really well in this quote: by locating disease in physiological difference, be it susceptibility or resistance. By the way, one of the justifications for forcing blacks to work in rice fields in South Carolina was that blacks had resistance to malaria and therefore they were suitable to working in swampy conditions. So whether it's susceptibility, which is much more common, or resistance, medicine serves to mark blacks as deserving of their inferior status in society. The practice of medicine linked to justifying the subservient status of blacks in U.S. society. Just as I say it, this is supposed to be a profession that helps people, but it was deeply implicated in justifying enslaving people. And I want to emphasize not just the practice of it, like Marion Sims performing experiments on women, painful experiments on women without anesthesia, but the theory behind it, the idea that people of different races have distinctly different bodies and they should be treated medically differently because of that. That idea finds its roots in justifying slavery. Now, let's fast forward. I talked about slavery. I talked a little bit about the Jim Crow era, where not only in the South, but in the North as well, there were separate medical facilities for blacks and whites. Remember I told you about Dr. Cartwright's theory about vitalizing blood. Blacks have a hard time vitalizing blood. And this was connected to the idea that black people have lower lung capacity than white people. And at the time, 1848, a lot of this comes together at the same time period where there's a need to justify continuing to enslave people, especially after England abolished the slave trade. They were abolitionists. in the United States a need to shore up the justifications for enslaving human beings. And so it's no coincidence that you're finding these medical ideas and measurements really intensifying at this time. And there was a device that Cartwright used to prove his theory about blacks' need to vitalize blood, their incapacity and the need to be enslaved in order to vitalize blood. A device called a spirometer, actually invented by someone in England to measure differences in different lung capacity, people of different occupations. It came to the United States, and all of a sudden it's not to measure any more occupations, to measure racial differences. And from the very beginning, the idea was that blacks have lower lung capacity, and so in measuring, using this device, you had to correct for racial differences in lung capacity. And to this day, there is a button on the spirometer marked race that doctors or technicians push and then put in. Have you heard of this? Have you seen this? Yeah, you put in the race of the patient and it changes the result depending on the race of the patient, based on this idea that originated during slavery. Let me just see something. Oh, I think I did. Let me see. Okay. I meant to bring this up later, but I'm going to do it now because I just want to emphasize this point that you may not even be aware of it, but many of the tests that you may have taken in the doctor's office, the results are different, are treated different. It's the same result, but it's treated differently depending on race. So my daughter sent this to me a couple weeks ago. Now she knows that, you know, I've been studying how doctors treat patients differently based on race. And yes, she said, "Mommy, look at this." Where is it? Here we go. Now this is the GFR, which measures some chemical based that has something to do with kidneys. And this is these are her readings. And if the doctor decides she's African American, she's told she has 89. But if the doctor decides she's not African American, she has 86. This is exact same, whatever it is, that's measured by GFR. But depending on her race, it's a different number. And you say, well, why does that matter? In fact, somebody said, so what? Well, apparently it should matter. If the doctor's measuring it, it matters, right? I mean, then don't give me the blood test if the results don't matter. But you can even see here that the results do matter. Because you're normal if you're 89, right? You're normal to mildly reduced if you're under 89. So now if the doctor decides she's African American, she's normal. But what if the doctor looks at her and says, oh no, you look like you're Middle Eastern. That means you're white, and now you're mildly reduced. Well, let's just imagine instead of 89 and 86, let's say it's 59. And, whatever the 40-something. At some point, there's somewhere where the doctor's going to get concerned. That means the doctor is going to be concerned earlier for a white patient than a black patient. Do you see what I'm saying? Now, that bothers me. I don't know, that bothers me. In fact, I was talking to some nurses about this, and I said, could it be? Can we see whether or not blacks get later care as a result of this? And then what's so interesting is that it has to do with kidney function. We know that blacks have higher rates of kidney failure. I'm wildly speculating now, but could it possibly have something to do with the fact that they're treated later because of this? Okay. just another example of how doctors currently, this is from, maybe it was 3 weeks ago, currently race still makes a difference. Now the assumption here is that black bodies categorically function differently from all other human beings, such that what's normal for a black person is not normal for any other human being. In the questions and answers, we can get into what that might mean. I mean, we could think of things like, well, what if you could be black and have mostly European ancestry or Asian ancestry? So how does the doctor determine which category you're in? Is that good medical treatment if that's how you're determining the meaning of that? Okay. So Sadie Satel wrote this article that was on the cover of the New York Times Magazine some years ago. I'm a racially profiling doctor, and she sort of wrote it like a provocation. Illness isn't colorblind, so why is it taboo for doctors to take note of a patient's race? This is just a total fabrication. It's not taboo for doctors to take note of a patient's race. Medical students are routinely taught when a patient comes in the office, you look at 3 things: their age, their sex, and their race. And they absolutely routinely take race into account in diagnosing the patient and in treating the patient and in prescribing medications. I just showed you 2 examples of how it's not only up to the doctor, but it's in the very machines and tools that they use. It's embedded in it. It's not even as if the doctor can judge whether it's important. The doctor is forced to take race into account in those 2 examples I gave you, but there are many others as well. Sadie Satel was saying that she's a psychiatrist and that she gives her patients psychiatric drugs, the dose of them, depending on the race of the patient. And she gives blacks lower doses than she gives her white patients. What does she say? Yes, I do this in part because clinical experience and pharmacological research show that blacks metabolize antidepressants more slowly than Caucasians and Asians. So blacks get a lower dose of antidepressants than her white and Asian patients. Let me just give you a few more examples of some of the ways in which race plays into medical practice today. Richard Garcia wrote this now pretty well-known article in Pediatrics telling the story of a childhood friend of his who had persistent lung infections and suffered horribly until she was 8 because, he's quoted from her medical records, 2-year-old black female with fever and cough, treated with, cough syrup and that kind of thing. 2 years later, 4-year-old black girl with another pneumonia. This child was having pneumonias and cough, horrible coughing and congestion throughout her childhood. Finally, when she was 8, a doctor who didn't know her race looked at the x-ray of her lungs and said, who's the kid with cystic fibrosis? She had cystic fibrosis, which could have been diagnosed from when she was an infant. And instead, she went for 8 years without proper treatment. Why? Because the doctors thought that only white people have cystic fibrosis. Black people do not have the genes that predispose them to cause cystic fibrosis. And therefore, despite her having the symptoms of cystic fibrosis, the doctors just neglected that was a possibility and did not treat her for it. Another example. Numerous studies have shown that black patients in pain, who express pain, who have injuries that cause pain, are not treated for pain as aggressively as white patients. This particular study showed that 43% of blacks, but only 26% of whites received no pain medication for long bone fractures. This is where this researcher looked at the X-rays. These are fractures of the bone that look the same, but the black patients were not given pain medication. And he even checked he did a couple studies, but one of them there was the criticism of the first one. Well, maybe black people don't express pain. They can just endure pain. It's just something about black people that they don't feel pain. And then he found in the charts that even when they said, "I'm in pain," which you would know they were in pain because they had a bone fracture, they still didn't get the medication. And there's another study that shows that opioids, a very more powerful form of pain medication, there's even a greater discrepancy. And one theory is that there is this myth out there that even the doctors have absorbed that black people, and this probably comes out of slavery times too, are able to endure pain better than other people and just don't feel pain. And there's all sorts of myths. Our skin is tougher. We're used to hard work. Or it's somehow in our genes as a result of slavery, or if blacks were enslaved because their genes made them more suitable for hard work. Another is that blacks are predisposed to drug addiction, so you don't want to give black people, that drug that all these famous white people are addicted to. What's it, OxyContin or something like that? But that's another theory. But whatever the theory, it comes from the idea that black people's bodies are different than white people's bodies, and therefore the doctor does not need to prescribe any pain medication or the same amount of pain medication. And one more example, this is a study out of Penn, Katrina Armstrong, who's a physician researcher at Penn, looking at records of patients with breast cancer, found that African American women were a fourth as likely to be recommended for BRCA1 and 2, the genes, the mutations that should present a greater risk of breast cancer, counseling for that even when they were clinically at risk. And again, this seems to be a case where doctors believe the myth that only Jewish Ashkenazi women have this gene, and therefore their African American patients couldn't have it, and therefore they don't need to be counseled about it. All of that is false. The fact that a mutation may be more prevalent in one population than another doesn't mean that it's only present in that population and not present in the other population. It also doesn't mean that African American women cannot have Ashkenazi Jewish heritage, ancestry. So it's just wrong-headed in every way, but doctors have accepted this myth and treat their patients accordingly. Okay, you saw that one already. I just want to add that Sally Satel had to issue an erratum. She had this on a blog because she says she was told by a number of physicians. I should mention, in her article, she said, well, and I also know this anesthesiologist who gives all his black patients a drying agent to dry out their throats before he intubates them, because black people salivate more. Just put that in the article, and then she issues this erratum, which says, well, people have told me they're not aware of this greater salivation rate of black people, But she said, but there are many other intrinsic differences, so that doesn't undercut the overall argument of my article. Now, I mentioned that Samuel Cartwright not only found that there were these different diseases common in black people, that black people experience common diseases differently, and how that has continued in race medicine today, but remember drapetomania, the idea that black people flee the plantation because of a mental disorder. So it's not just the enslavement of blacks he was justifying, but he was also figuring out a way to repudiate and stigmatize the resistance of black people. And here is another modern-day example of this. The transformation of schizophrenia from a disease that was thought of to be a white person's disease to a disease considered to be a black person's disease. Jonathan Metzl, who's a professor at Vanderbilt, wrote this book, The Protest Psychosis, How Schizophrenia Became a Black Disease, where he traces this remarkable mutation of this mental disorder that used to be associated either with white male poets and artists or with white housewives. And it was supposed to make them calm, even, kind of spacey. And then the 1960s came, and there was unrest in cities around the country, and all of a sudden, black men started to be diagnosed as having schizophrenia, and the very symptoms of it changed from sort of being out of it to being violent. The drugs for it changed, and so this is an image from his book. This advertisement in, here we go, in a psychiatric journal for Haldol, and you see the image that goes along with it is kind of Huey P. Newton looking, right, aggressive black man. Now he also focuses a lot of the book on a mental institution outside of Detroit that was all white, was filled primarily with white women. And over the course of the 1960s, the population transformed completely into being filled with black men. And it even shows how the very diagnosis is scratched out on the records of white women from schizophrenia to depression or something like that, and how the black men coming in all are diagnosed as having schizophrenia. It's just an amazing, I highly recommend this book. It's an amazing example of how you can see race affecting medical diagnoses right before your eyes. And I won't go into how these men were treated. I mean, the psychotropic drugs, electric shock therapies, and they were being held. They weren't convicted of crimes. They were being held in there for mental disorders, which means that you could stay there the rest of your life, and many did, until the doctors decided they were cured. If they said anything angry, if they protested their being locked up in there, that was evidence they had schizophrenia and they had not been cured. And one marvelous thing about this book is he's got the records there for you to look at. So if you don't believe it, you can see the medical records and what these psychiatrists did in transforming this diagnosis. Another aspect of race medicine is the idea that doctors are importing these racial ideas, maybe even subconsciously, as a way to benefit society. And I want to emphasize how, in the name of helping people, when people are divided this way as naturally different by race, it can lead to the most horrific results. So another one of these from 1933 to 1973 stories, the eugenics board in North Carolina operated from 1933 to 1973 when a newspaper reporter leaked the news that people knew, of course, in North Carolina, that women were being sterilized, compulsorily sterilized by this eugenics board, or by orders of the eugenics board, all the way into the 1970s. And the justification for this was that these women, who by the 1970s were primarily women on welfare, that this was for their good and the good of society because they were having too many children while on using taxpayer money. Now this idea continues in July of 2013. Corey Johnson, another reporter, thank goodness for these reporters that shed light on these practices that of course people know are going on, but the general public may not know, that California had instituted a program of sterilizing incarcerated women. And there's dispute about how ethical or unethical that is to sterilize a woman who's incarcerated. Some people would say it's unethical to do it at all, but these were being done illegally because they were not getting the approval that California state law requires for the sterilization of an incarcerated woman. This Dr. James Heinreich was supervising these sterilizations, about 150 sterilizations, and a quarter of them at least were women who said they never consented. Some of them didn't even know they were being sterilized. And look at his justification for it. Again, very eugenicist justification that he was basically saving the state of California money because what was spent to sterilize them wasn't a lot compared to what the state saved in welfare paying for these unwanted children as they procreated more. So this theory that it's all right for doctors to perform procedures that are not of the will of the patient, that may be extremely damaging, painful, harmful, change their life prospects for the good of society, that justifies it. That idea is still present in medical practice today. And what does that have to do with race? Well, in both of these cases I just showed you, the victims of these policies are at least disproportionately, if not primarily, women of color. In the case of North Carolina, black women; in California state prisons, black and Latino women. Now let me turn, do I have like 10 more minutes?
Take as long.
Okay, okay. Let me turn to a new development, which is the subject of my book, Fatal Invention, that I fear is intensifying this use of race as a natural division of human beings in the practice of medicine. I noticed this development in actually after the mapping of the human genome, which was declared to show that we are not divided by race at the genetic level. And yet, right around that time, I started seeing commentary that the Human Genome Project was going to allow biomedical researchers and genomic scientists to discover more about the genetic differences between human races. So Nicholas Wade in the New York Times, I guess I didn't put that down there, but this is, may have even been a front page story in the New York Times. I can't quite remember, but it was a prominent story in the New York Times. is looking at what is the future of human genome research, and he declares that it's looking for genetic differences between human races. You know, I read that, I thought it was just the opposite. I thought that what scientists would be planning to do in the next phase of the Human Genome Project would be to figure out a new science of human genetic diversity and commonality that no longer relied on the myth that human beings are naturally divided into races. So I'm looking for that instead. I see that he says it's the opposite. It's just continuing the same thing, basically, that Cartwright was doing, except he didn't have the Human Genome Project to have them. It's like, now we have the Human Genome Project, so we can do it even better than Samuel Cartwright did it. And he has only continued down this path, leaving the New York Times to write this book, A Troublesome Inheritance, Genes, Race, and Human History. It was published in May, where again he says that the evidence for the mapping of the Human Genome Project allows him to write this explosive new account of the genetic basis of race and its role in human history. So now he's going beyond saying that genomic scientists can prove that races really are divided according to genes, but that explains all of human history. That explains the success of certain societies versus other societies. That human beings evolved into different races, and each race has a predisposition toward certain kinds of behavior, and that explains basically, why Europeans are superior. Although he doesn't say that. He says, I'm not talking about superiority, I'm just talking about genetic advantage, he says. But it sounds like superiority and inferiority to me. And as I looked into it, I found that indeed there were many, many, many scientific articles that were using a genetic definition of race, defined as clusters of genetic similarity that evolved when human beings left Africa and separated onto different continents. And then biomedical research that is looking for genetic explanations for health inequities. So let's look at this very stark and troubling racial inequity in this country, which has existed since the time of slavery. This is another aspect of race, medicine, and health that continues from slavery with changes, but pretty much the same story until today, which is that blacks have a much higher rate of infant mortality, babies dying in the first year, than whites in this country. And in fact, as the statistic shows, it's gotten worse since the 1950s. Now, why is it? Well, this study, published in 2007, tests the hypothesis that it's because of something called black race. Black race, independent of other factors, increases the risk of extreme preterm birth and its frequency of recurrence. And just that idea, what is that there is something called black race independent of other factors. So if you strip away the social context, you strip away the environment, you strip away racism, you strip away segregated neighborhoods, you strip away everything, you're left with some essence of black race that predisposes anyone who has it to extreme preterm birth. Now, the study doesn't define what they mean by black race, who belongs to this black race. I mean, how much of this black do you need to be, to have this predisposition? It just doesn't say. And how do you determine what that is? Doesn't say. It does like what most studies do, is they just either ask people, what is your race, or the researcher decides, you look like this, I'll put you in that group. And we know in the United States Black is defined as anyone who has any trace of African ancestry. So if I can look at you and I can think that somewhere there I see an African ancestor, but not too far back, because we all have African ancestors, but not too far back, sometime that period where the race is separated. I'm not sure exactly when that is, but that no one can tell me when that is. But there's some period in time, apparently, where the race is separated. And if your ancestors, any of them, come from that pure black race, pure black, they don't explain why the rule isn't that if your ancestors, any of them, come from that pure white race, you're white. Why isn't that the rule? There's no genetic reason for it. There's a political reason for it. Again, it was an invented rule. It's totally invented. But for those of you, anybody here who doesn't believe me that race is invented, just ask yourselves, what if we change the rule that anyone with any European ancestry is white? And just think of all the black people you know who are, or Asian people, or Native American people who are now white. Their genes don't change. It's just the rule that changed. What does that mean to you, to think if the rule were changed, all these people I now think of as a different race than white are now white? How does that change my view of the world? What would happen to all those tests that are determined by race? So they control for a few factors, and then they reach the conclusion that their findings suggest a probable genetic component that may underlie the public health problem presented by the racial disparity of preterm birth, and it gets a headline in the New York Times. Some other researchers point out that you don't get this racial disparity if you look at women born in Africa who came to the United States. Their babies are the same weight and the same gestational length as white women's babies. It's only women who have lived in the United States, black women who've lived in the United States, who have this problem, which suggests that it's not about genes, it's about something bad that happens to black women who live in the United States that causes this problem. Okay, I'm going to move ahead. I'm not saying that race doesn't have any connection to biology or health. I told you that for centuries, black babies have died at higher rates than white babies in the United States. But what I'm saying is that's not because there's some innate predisposition that black people have for their babies to die. It doesn't even make sense under evolution, natural selection principles. But it's because race is a real political category that does have biological consequences because of the impact of the social inequities that are experienced by people categorized in this way on their health. This idea of separate human races, biologically separate human races, has now been incorporated into medicine, into medical products. As I said, it's been incorporated into medical practice. But one of the results of the high-tech gene-based application of this idea is race-specific medicine. And the Food and Drug Administration approved the first race-specific drug, a drug called Bido, a therapy for heart failure, which was developed without any regard to race whatsoever. It's a combination of two generic drugs that are prescribed without any regard to race for 20 years. Cardiologists figured out how to put them in one pill. He used them, this therapy on his white patients. He patented it without any mention of race whatsoever. And it dilates the blood vessels. It dilates the blood vessels of any human being who uses it. But he had to get a second patent because the drug wasn't approved by the FDA at first. He needed a novel claim. He added to the patent that it was for African American patients. He didn't change the formula whatsoever. The FDA allowed him to perform a clinical trial involving only African Americans, and it worked. And, and the theory was, you've shown it worked in African Americans, so it can only be marketed to African Americans. I mean, most of the drugs that black people use in this country were only tested on white people. You know, but you think about what that means, that if it's tested on black people, it means it can only work in black people. We only know it works in black people. I mean, we know it works in other people too, but so the head of the committee that approved this said, we're using self-identified race as a surrogate for genetic markers. This had nothing to do with genes. No one's genes were tested. This is a cardiologist. He didn't know anything about genes. He just knew how blood vessels work. But to justify it, after the fact, they say, well, it works on black people because there's something in their genes that either makes their heart failure different or their reaction to this drug different. Now, I just want to put this in context, this development, and I mean this resurgence of the biological concept of race in medicine in the social context of a retreat from affirmative action policies and any government policies that use race as a way of remedying past and continued discrimination. And most of the justices on the U.S. Supreme Court, as articulated by Chief Justice Roberts, have voted to strike down multiple efforts by state, federal, local governments to address discrimination affirmatively on the grounds that the government cannot explicitly use race in its policies. Notice I just told you the FDA, which is a government agency, allowed for a race-specific drug. Why isn't that a violation of the U.S. Constitution? Why, according to this rule, the FDA violated the Constitution by allowing that, because it's discriminating either against non-African Americans or African Americans. And so, I'll just go on. What I think we're seeing is that racial differences are seen as real at the molecular level, so it's all right to have a racial label on a drug, on the theory that races really are different in their biology. But race is seen as merely constructed in society. It's not real in society, so it's all right to strike down affirmative action policies because we don't need to pay attention to race in society. We pay attention to race at the biological level, but not at the social level. Is that how that theory goes? Now, so far I've talked about the use of race in medicine and biomedical research. And I definitely don't have time now to go into other extensions of that. But I just want to put in your minds the question that if we accept the view that race is a natural division of human beings, and that medicine should be practiced according to race, and that biomedical research should be done according to race, what about other traits besides health traits? What about predisposition to violence? What about predisposition to high intelligence? What about predisposition to other kinds of antisocial behaviors? All of these are examples of behavioral traits that have also been linked to genes and also linked to race. And just to give you an example, there's a researcher who says that he has found the gene that predisposes people to gangbanging. when the AP, the Associated Press, published a story online, they included this photo underneath, which, for me, I mean, it could mean different things to different people, but for me, it's a very racialized photo. It's a photo that I think speaks to many Americans' association of gang banging and violence with people of color, and it also has a very punitive response to it with these paramilitary agents with guns lined up behind the gangbangers who supposedly are genetically predisposed to be violent. And so, to me, these developments are leading to a wrong direction in how to address health inequities in this country, but also other kinds of inequities. Inequities in incarceration rates, inequities in school performance, for example, that take social hierarchies as facts of nature, that these inequities we see of people of color being disproportionately arrested and convicted and incarcerated, doing more poorly in schools, and their health being poorer, that all of this is natural. It's because of a natural difference among races. And what's the solution for that? Not social change. You don't have to change society, because again, that's just constructed. It doesn't, you know, it doesn't. It's not really. It's not really real, and it's not going to do any good anyway, because supposedly these inequities are written in people's genes. And so what you need are race-specific medicines, technological answers, and as that other slide shows, punitive control. All you can do for people who are predisposed to violence is violently contain them. I would argue that that wrong direction is based on a myth about human beings that was created to justify inequities and unjust social hierarchies. And instead, we should be working to affirm our shared humanity by ending social injustices preserved by the political system of race. Thank you.
So now we have some time for questions and responses and debates.
Well, thank you for coming first. It's a very interesting, provocative talk. I'm curious how you, listening to this, I agree with most of what you say, but I think in some genetic science there has been. You mentioned at one point
Ashkenazi Jews.
Jewish populations
Yeah.
with the BRCA mutation. Another thing that comes to mind is I know that couples who are both of that ethnicity who are trying to conceive will often be screened for certain other diseases
Tay-Sachs, right.
Tay-Sachs, lysosomal storage diseases, which are shown in their populations 4 times greater. You're not suggesting that should be done for all?
Well, in some cases, it does. We could ask. I mean, we should ask the question. So let me start with what that means. That you can identify populations that have higher rates of a particular genetic mutation than other populations, and then get to this question of screening. So, yes, it is true that you can identify populations that have higher frequencies of certain genetic mutations than other populations. I mean, that's absolutely true, but that doesn't mean that those populations that have higher rates are categorically the only ones that have the gene and the others don't have it. It's also important to note that you can find genetic difference. I'm not saying all genetic differences are of equal concern, but you can find genetic differences between any groups. Like I could take each of these groups of chairs here, you know, and 3 here, and I will find that this has a greater frequency of some allele than this one and this one. So yes, there are differences, and I don't mean to be, you know, cute about it, that it is the case that we're not all identical. There are genetic differences in families, right? So the fact that there are genetic differences doesn't make that group into a race of people, and it doesn't mean that they are different from all other groups because of a variation. You have to ask a lot of questions about the significance of the variation. I mean, it could be that one population, 50% of the people have a particular mutation, and in another 51% of the people have it. Well, is that a difference we should really care about? So, you know, what is the difference? So even with the BRCA1 and 2 mutation, it's not the case that all Ashkenazi Jewish women have it, nor is it the case that all non-Ashkenazi Jewish women don't have it. It's a mutation that increases the risk of breast cancer. So part of it is just, what are we even talking about? So a lot of times we'll say there's genetic difference as if that determines the fate of a group or an individual, that it categorizes the group as different from all other groups. All we're talking about is a different frequency of a mutation. And having the mutation could mean different things, and the frequency. So it's really important to go back, if you've got a taste for it, go back to some of these studies that say, oh, black people have this, and white people have this, and Asian people, and look at what the difference. Sometimes the differences are so tiny, it doesn't make a difference. And this gets to the screening. Because there's some differences that are so small, it does make sense to screen everybody. Or it may be that there's so little of it, it doesn't make sense. It doesn't make sense to do screening even of the group that has a higher percentage. Let's say one group has a 0.0001 chance, and the other group has a 0.00015 chance. You know what I'm saying? You've got to. So often these differences are accentuated as if they determine more than they actually determine. And then another question about this is, well, Ashkenazi Jews are not one of the races, the 4 or 5 or 6 races that I'm talking about. These large categories: black, white, Asian, Native American, some people would say Latino, that we call races in this country. Those are invented groupings that are determined by social rules. In other words, there's no way you can know who is black, who is white, who is Asian, who is Native American without asking, well, how do you define it in this country in 2014? The rules have changed. I tried to emphasize that in my point about how we define black versus white. Could be flipped. It's different in different countries. So that's what about Ashkenazi. Where do Ashkenazi Jews fit in that? Well, if you ask today, I think they would be classified as white. If you ask somebody in the 1920s, if you asked a British person, an English person, are Ashkenazi Jewish people the same race as you? The average white American would say, no, are you kidding me? No, they're a different race of people. Now, almost 100 years later, they're considered white. So doctors conflate. I've got a white patient. The white patient may have the BRCA1 and 2 gene because they're conflating Ashkenazi Jews and white people, but that wouldn't have been done 100 years ago because the definition changed. So, yes, there are populations, there's lots of different kinds of populations, but we can find populations where we can see that they have a greater frequency of an allele that's significant. But again, that doesn't define that population as a separate race. And it doesn't mean that they have it, but no other population has it. Yeah.
I have one little comment that is related to that, and then a question. I went to a doctor in New York City. I said to the doctor, I have Crohn's disease. The doctor said, no, you don't. I said, I do. He said, Mexicans don't get Crohn's disease. Jews get Crohn's disease.
Yep.
I said, I'm not Mexican. He said, it doesn't matter.
He says, I think you're Mexican. So you're Mexican.
Then he took the x-ray, came back and said, you have Crohn's disease. I said, I told you that. Now, how is this related? Historically, Ashkenazi Jews apparently have higher rates of Crohn's disease. But if you look at it now, it's actually changing. More people are getting Crohn's disease, are being diagnosed with it. So that is, and the medical profession is catching up.
Yeah.
Now, my question is,
Yeah.
related to that,
Yeah.
if that doctor had been Latino, would he have come up with the same thing? In other words, do you find in these studies that African American black doctors apply the same type of stereotypes, the same type of preconceptions to the patients? As
Yeah. Well, first of all, I can't answer that because I have not done, nor have I seen a study that looks at that question. They may exist. I wouldn't be surprised if there were a study that looked at the race of the researcher or the doctor. I just can't cite it right now. From my experience working on my book and talking with a lot of doctors and researchers, I found that they are more sensitive to this issue, but many have been trained to practice in race medicine, and they may sometimes have different motivations, but they have the same training. And so again, I can't answer your question definitively, but I would just say that I think it makes a difference, but it doesn't necessarily mean that the doctor isn't going to treat patients according to race. One of the biomedical researchers I interviewed and write about in Fatal Invention is of Mexican heritage. His mother is Mexican, his father's white, I believe, pretty sure. And he identifies as Latino, and he is very committed to expanding biomedical research of people of color, especially Latinos, bringing more Latinos into biomedical research as researchers. But he's also looking for a genetic explanation for why Puerto Rican children have higher rates of severe asthma than Mexican children. And his theory is that Puerto Ricans have more African ancestry, and so there must be some African gene that is causing this. Now, I spent a lot of time talking with him. I think he is sincerely trying to help Puerto Rican children to have less asthma. And it's so fascinating talking to him because he understands social race, in America. He understands discrimination, he understands the history of racism, but he was trained to do research this way. And he also believes that this is the best way to get attention to this health inequity. So there's a lot of things going on here. I won't put it all on him, but in interviewing him, I saw three things. One was a real concern, but training that led him to look for a genetic explanation. The other was this idea that because genetics is so popular, that if you want money to do research and you want money invested in a solution, it's got to be a genetic explanation. I could go on and on what the way in which the belief that in order to get for people of color's health issues to get attention, you've got to emphasize the difference. You know, and then the genetic difference gets you that extra attention. And then the third is many researchers want to find a product that they can patent and license and make money from. And their universities want them to do it. There's a lot of incentive and pressure. And you are not going, if you believe that the reason why Puerto Rican children have such high rates of asthma is because they live in neighborhoods where, like the South Bronx, where there's a lot of expressway traffic, and they're breathing in these toxic fumes, and there are other environmental reasons that have been linked to these particular neighborhoods for high rates of asthma. If you believe that, you're not going to make money off of some pharmaceutical. But if you believe that you can identify the gene and there's some kind of way that you can make a special medication, or maybe in the future come up with some gene therapy or something like that, you can imagine a product, a profitable product. As I mentioned with Bidel, the whole reason that turned into a race-specific drug was a commercial reason, because it was the only way to get it patented, which is the only way you can make money off of the drug. I had a debate with Jay Cohn, who developed this drug, and at one point he just broke down and said, Dorothy, you just want to change the way that pharmaceuticals are manufactured in the United States, but that's not how it's, this is the only way I can make money off of my drug. I had to patent it. So that's another piece of this, and it's just, this is why I had to write a book about it, because there's so much to this. Just your question that goes into it. Part of it is also the need to have a special interest group with special, that you can make more special and different to get political attention to that group. And the feeling, even there were black people who supported Bidel and testified in favor of this. This is the federal government showing they finally care about black people's health, giving us our own drug. No, seriously. Seriously. So there was that political part of it. Then you've got the black cardiologists who were in charge of the clinical trial. This was one of the largest clinical trials of African Americans in the country. It enrolled more black women than any other clinical trial in the country. And in charge of it was the Black Cardiologists Association. Okay, so here is a case. Usually they don't get to be out front in charge of a big clinical trial that's going to produce a drug. It's a field dominated by white cardiologists. They have their chance now. And so were they going to say, oh, we oppose this, what are you talking about? We know that black people's hearts don't work differently than other people's hearts. No, some did, but most of them said, let me jump on this. And so all of these forces, political, commercial, ideological, historical, legal, come together to push the research in that direction. But, understand that. Do not be fooled into thinking, oh, this shows that black people have a different kind of heart failure. Come on. If you think that, you are so naive. You are so naive. It didn't show that whatsoever. If you think this shows, oh, there must be a genetic reason for higher rates of heart failure. No. It shows the power of profit, of racial ideology, of racial politics. That's what it shows. And that's what's steering this science. So when scientists say, oh, let us just do our good science studying racial differences at the genetic level, who are you fooling? Come on. We're neutral. We have no influence from the outside world. We're just neutrally studying this. Are you kidding me? You're being influenced by politicians, by an ideology you may not even be aware of, by the way you were trained in medical school, by the profits that you want to make. All of that is influencing it. Yeah.
So there's a movement right now in biomedical research to start recognizing that women have different biology than men, right? And there's more women in clinical trials and more women in animals and animal studies.
Yeah.
So I'm wondering about how the arguments you're making about race-based medicine might apply to gender.
Yeah, that's a tough one. I decided in my book not to really go there because it would have been too complicated. But I don't have the same approach, but there's some aspects of what I'm saying that I think apply to looking for sex differences. Because I think we have to be very vigilant about what we see as categorical sex differences that really are a result of the way we've been trained to think about the differences between men and women. And there's a lot of that. So on the other hand, I think that race is completely invented. I don't believe that about sex differences. But I don't think sex differences are in the strict binaries that many researchers employ in doing their research. And I think there should be more research about the commonalities and also about what creates the perceptions of difference. The same thing as in race, the perception of difference and treating people differently because you think they're innately different can lead to real biological differences. So that's an interesting area of study for sex and gender as well, I think. So I think there's similar questions, even though I don't see the categories as being exactly the same. But I did read a story in the newspaper recently about more money being put into the study of sex difference. And some of the comments I was troubled by. And it seemed as if, like in the press release and that kind of thing, it seemed as if it was emphasizing, again, this stark dichotomy that didn't take into account the ways in which social expectations and norms can lead to different biological outcomes.
I sort of have two questions. First being, do you think that the Human Genome Project will help with personalized medicine? Okay, so from there, do you think that, or at least moving toward the future, do you think it'll help cause a shift away from this race medicine and more towards that personalized medicine?
Great question. So one response that I have gotten to, and others have gotten to, this objection to the resurgence of biological race in genomic science and biomedical research is, okay, we know race is a horrible proxy for genetic difference, but just hold on, don't get upset, don't give lectures on this yet. Just wait, because from the knowledge we're getting from the Human Genome Project, we will soon reach the age where every patient is, the whole genome will be scanned, and and doctors will be able to more precisely diagnose disease with this personal genetic information and prescribe medications that target or prescribe according to this personal gene profile. Now, I'm skeptical of that, and I'll tell you why. Number one, this idea of personalized medicine is part of what promoted the money spent on the Human Genome Project, and it has not materialized. You keep getting these predictions. We're going to be able to do it right around the corner, in the next decade, and it just hasn't happened. And many of the projects that genomic scientists were involved in that were predicted to show the gene for every disease, it just hasn't panned out because they're finding that their framework was not right. That it's much harder to find a gene or even a combination of genes that predisposes people to a particular disease, especially a common disease, much harder to find. They just haven't found it. I mean, we know, we haven't, and there's some examples. To me, the best, most hopeful that already are happening is for example, testing tumors themselves, the genetic, but to find the genes that predispose people to cancer, to diabetes, it just hasn't happened. I mean, the medications, now maybe it'll happen soon, but let's say it does happen. Everything I've been talking about shows you how race is so embedded in the way medicine is practiced and research is done, and products are sold, that I'm not so sure that it's going to change just because the medicine has advanced. The way the medicine advances, as Bible is such a great case of, is already got these racial assumptions shaping it. And then to sell it also. Because no company is going to produce medications that are so specific that they're according to any particular gene or combination of genes. I mean, they would be so expensive. Companies have to find niches, and race is a great niche. And we already, I don't have time, I see Dr. Smith standing here. There are already examples of tests for specific genes that are marketed by race. Because people just, they're more, if you say this is a medicine for your gene, people might listen to it. If you say this is a medicine for your race, for some reason, many people think it's more for them than even if it's for their particular genetic makeup. So it helps to market products. And so the long and short is, I think that we cannot depend on advances in genetics addressing racism or racial thinking. I'm not saying you were saying that, but I mean that's the lesson. I think we have to tackle the racial thinking that continues to shape both the design of the research and the outcomes of the research and the products produced by the research, in order to ensure that whenever we have personalized medicine, whenever that happens, that it's not divided by race, it's not prescribed by race, and also, just as important, well, yes, I'd say equally important, but no more important, is that everyone has access to it, which is another thing I didn't spend much time on. But there is such inequity in access to medicines and high-quality health care that you can have the most fantastic test available, but if people don't have access to it, it doesn't do them any good. And we know that these very expensive tests that are gene-based tests are not mammograms aren't distributed equally in this country, let alone very precise medications tuned to particular genes. So that's another part that we have to ensure as well. Thanks.
Thank you so much, Dorothy. Even beyond an already rosy
Oh,
expectation.
thank you. Thank you very much.
And thank you all for coming.